In our state, more than most others, we make ourselves sick. We either don't take care of ourselves or don't consult those who would keep us healthy. So our rates of cancer, heart disease, diabetes, obesity, stroke, and other diseases is far greater than need be. The cost of preventable ailments costs the Arkansas economy, to include the Arkansas taxpayer, hundreds of millions of dollars each year. Are there solutions, and are we pursuing them as we should? It's our focus on a special edition of Arkansas Week.
Support for Arkansas Week provided by the Arkansas Democrat-Gazette, the Arkansas Times, and KUAR-FM 89.
Hello again, everyone. Thanks very much for joining us. It is neither fair nor accurate to call Arkansas a sick society. But Arkansas as a whole is sicker, literally, than much of the rest of the nation. On a per capita basis, our people endure more heart attacks, more strokes, more diabetes, more cancers than the citizens of most other states. And in many such cases, Arkansans do not endure, they die. 2, ethnic disparities are sadly manifest. For the next half hour in this special edition of Arkansas Week, our too many ailments and what can be done about them. We're joined by Sharonda Love, Director of the Arkansas Minority Health Commission, Dr. Bala A. Bala, Director of Chronic Diseases for the Arkansas Department of Health, and Dr. Joe Thompson, who's President and CEO of the Arkansas Center for Health Improvement. Welcome to all.
Thank you.
Dr. Thompson, let's start with you for an overall. It's a pretty discouraging situation when you look at it as a whole. These statistics, these disparities, Arkansans, and so many of these ailments are 5 to 7 to 8% greater per capita than they are in other states.
You mentioned it at the outset. Arkansas is a beautiful place to live, to raise your children, to have vibrant community participation, but we are challenged by health risks that manifest themselves ultimately in disease and conditions that take our loved ones. And those are borne more significantly and more severely by low-income communities and communities of color. We've got to figure out a way to actually make investments so that we go upstream to decrease some of these risks, because we're not going to be able to pay for the healthcare costs downstream as they cause conditions, they cause heart attacks, and they rob people of their function, and we have to support them in the end stages of their life.
Well, we mentioned at the top of the program the cost. We're spending billions in a state of 3 million people. We're spending billions in state and federal revenues every year.
And I think people don't recognize, it's the upstream risks. Almost 1 in 4 Arkansans continue to use tobacco in some form. We have over 60% of our adults that are either obese or overweight. Those upstream risks are what ultimately cause downstream conditions of high blood pressure, of cancer, of heart disease. So it really is important for our communities to make sure that it's the upstream risk that we're paying attention to, not just the downstream healthcare system that we must have.
Yeah, Dr. Lee.
Yeah, thank you for having us. Just to add to what Dr. Thompson mentioned, some of the disparities are pretty glaring. When you talk about heart disease and stroke, for example, the risk among minority populations, especially among African Americans, can be 50% higher, or for stroke, it's twice that of the white counterparts. Working with upstream factors is very critical, like obesity, physical inactivity, and tobacco use being big players, and even going further upstream, looking at social determinants of health, like what is causing the people to yield themselves to risky behaviors like tobacco use or eating poorly And when you look at it, some of the social determinants of health, either it be low income, transportation, housing, and neighborhoods play a very critical role in impacting their health choices and consequently leading to higher heart disease or stroke or diabetes in our state.
Yeah, Ms. Love, picking up on Dr. B, the latest statistics that I was able to assemble indicate that an African American in Arkansas is more than twice as likely to suffer from diabetes as a white Arkansan. Some of these disparities they leap out at you from the stats.
For sure. So the CDC reports that minorities continue to have lower socioeconomic status, greater barriers to access to health care, greater risk for and burden of disease compared to the same or the general population living in the same county or even state. So like Dr. Bala said, while our zip code should not impact our health, it clearly does here in our state. And we can see that in our Delta counties on the eastern part of our state, or even in our southwest and portions of our northwest Arkansas counties where we have higher minority populations, we see a burden of disease and a risk for death that's 7 to 12 years greater in minority populations.
Downstream, upstream, we adopted the Medicaid expansion in Arkansas, and our uninsured rate in Arkansas now is a fraction of what it was, certainly compared to those states that did not expand under the Affordable Care Act. So access, it would seem, has been greatly enhanced. Are we seeing yet the impact of that greater access, or do we have to wait 2, 3, 4 more years before it bears fruit?
I think it's important, Steve. The expansion of coverage dealt with the financial barrier to individuals receiving care. We still have some of the same access issues of not having enough primary care providers across our entire state, or even specialty providers in some parts of our state. So we dealt with the finance issue, which was clearly a first root cause. We had to deal with the finance, but we now got to deal some with the distribution and the availability of healthcare services downstream. But I'd like to come back to something that Sharonda said and Dr. Bala emphasized. The statistics are glaring on the disparities of, again, low-income communities and communities of color. But it's not those individuals' fault that they have those conditions. It is about the determinants of health in the environments that they live. The term social determinants of health is a fancy name to say, the neighborhood that you live in, whether it's safe or not for you to be able to get out and walk, whether you live in a food desert. If the only place that you have to buy food is a local convenience store tied to a gas station, you're not going to have a healthy diet. If your opportunities in the community for employment or education don't give you the tools to be able to better yourself, then you're on a pathway that is not going to lead to a healthy outcome. And so it's those social determinants. With the legislative body, what I have found works is zip code risk. It really is. Your zip code determines your future health to a large extent, regardless of what your individual behaviors are.
Dr. B.
So to add to that, access to health does not necessarily translate all the way to accessing health, because while the Medicaid expansion in Arkansas helped significant number of people having the access, we still have challenges people accessing those care, either it be because of the low health literacy or transportation issues, and frankly, in some instances, it may be still the fear or some of the old thoughts about accessing some negative experiences in the past they had with the health system. So it's a little more complex. So while it improved the accessing care is still need to be worked on in the state for the bigger population.
Yeah, stepping back for just, I'm sorry, Ms. Love, go ahead if you want.
Well, and I agree with everything that's been said. I also think that it's access at multiple levels, like has been mentioned. We have to make sure that once individuals are in the doctor's office, that they're also comfortable with taking questions so that they're able to get their specific questions answered, and that they're not walking away from the doctor still with not having an understanding of what their disease is. I'll give an example. We do health fairs regularly in the community. There was a lady that came in to the health fair and said she saw the doctor. They told her to reduce her red meat, and she said, oh, that's not a problem for me. So when asked, oh, do you not eat pork or beef? She said, well, yeah, but I always cook it until it's well done. So it's making sure that the health literacy level and that there's cultural competence there to understand that because we talk at a certain level, we may need to have plain language that everyone understands.
And that goes back, does it not, to the necessary or the increase that would appear to be very necessary in terms of minority physicians, nurse practitioners, clinicians of all kind, because there still exists a significant, in many cases, a significant cultural gulf and even mistrust among African or people of color and white clinicians, physicians or nurses,
For sure. So we just published our 2019 racial and ethnic disparities healthcare study that looked at white, urban, and rural groups, black, urban, and rural groups, and Hispanic groups. And there were significant differences across all of the questions that were asked, especially as it relates to whether whites versus blacks and Hispanics felt discrimination when they went in to see the doctor, if they felt that they were able to actually access a doctor of their same race and felt comfortable with discussing and asking questions. And so those are all issues that I think that are important that we have to address when looking at health disparities, specifically healthcare workforce diversity and cultural competence training for those healthcare providers, from the receptionist all the way to the doctor.
And here's another issue that we touched on earlier. Even if anyone goes to a big box grocery that has 8,000 different varieties of fresh fruits and fresh vegetables, it is still more economical to eat poorly than to eat smart.
Yeah, unfortunately, yeah.
Huge obstacle,
if you can go and buy 99-cent burger and fries versus what we considered it would be better to have fresh fruits and vegetables or even canned vegetables with no sodium and no sugar added. But if we can drive through and get McDonald's and go home and feed our kids and not have to worry about working after or cooking after a long day of work and activities with the children, that's an easier solution for most families. And it works, unfortunately, for the current time, not for the long range and for their health.
Right.
You know, on a positive note, these are very valid things Sharonda mentioned and challenges we face as a state, and the Arkansas Department of Health is working with the Arkansas Coalition for Obesity Prevention in decreasing some of these barriers. For example, we have a program called Double Up Food Bucks. These are for SNAP recipients. For if they buy $3 worth of fruits or vegetables, they can get $6 worth of produce. So we are having a Double Up Food Bucks program. We have farmers market. We've collaborated with them to create farmers market in pretty much every city and every town, and we have a mobile farmers market where the market is taken to some of these neighborhoods where there is no other option except for a gas station or 7-Eleven. So we have been trying to promote the affordability to these fruits and vegetables, which are important, and every bite counts, and so is every step counts. So we are also working with the city planners and city governments in making our parks and sidewalks safer, and have some joint use agreements with the schools. Now that it's summer, the schools are closed, and every school has a school basketball court or gym where the community members can come and use it to increase physical activity. So as a state, we need to realize that every bite counts when it comes to what we eat, and every step counts when we engage in physical activity for a day.
Yeah, Dr. Thompson.
I think, on the positive side, we are increasingly aware of some of these upstream risks, and I think the literacy is an important investment. Having people understand that their obesity or their lack of physical activity leads to a downstream set of problems. Most folks don't really understand the development of disease. They expect for us, when we get diagnosed with something, to get fixed. We are making progress on having individuals understand upstream that there are things they can do each and every day that are going to help them avoid some of the disability, some of the costs, some of the effects of downstream health. What we've not done successfully yet, but Dr. Bala mentioned several, the Governor's Healthy Active Arkansas initiative, I think, is a broad effort trying to address workplaces, and we've now got employers that are looking to see what's in the vending machine. Let's make sure there are healthy options, sometimes only healthy options. Let's have a work break instead of, or a physical activity break instead of a smoking break. Let's have in the schools efforts we've got now. I think we've got close to 50 schools that have been funded to put water bottle filling stations in so that the students can have water options on a regular basis. We've tripled the number of hospitals that are baby friendly, and that every child delivered starts on a breastfeeding kick. We are making slow progress. What we've got to do is make the healthy choice, as Sharana said, be the easy choice for everyone. The healthy choice too often is now either the difficult, or to your example earlier, the most expensive choice. And we've got to make the healthy choice be the easy choice, and we're making small incremental steps forward, but we've got to recruit an army and have a campaign.
Well, at what point do, obviously, public health and public policy, political decisions affect public health. And they intersect repeatedly. Certainly they have over the last decade in Arkansas in terms of the Affordable Care Act. What's the next big challenge, as you see it, all three of you, for public policy in Arkansas? Ms. Love, we'll begin with you.
I think we start with instead of a sick system, a well system. I think we have to move forward with prevention and providing access to preventive health care, and encouraging our citizens within our state to focus on how to be well, like the Department of Health's new Be Well program. Instead of when we get sick, we go to the doctor and try to fix it, like Dr. Thompson said. And so the Arkansas Minority Health Commission has recently purchased a new mobile health unit where we are driving into communities of need, partnering with Arkansas Food Bank food pantries to provide free preventive screenings when individuals are picking up access to healthy food, so that we can provide health education and preventive screenings and help individuals to know what their numbers are. If they receive positive numbers, and we can say, continue doing what you're doing, and here are some ways to improve your health and continue to stay healthy. If they have negative numbers, then we can say, okay, here's how to get access to a physician if you don't have one, and these are some things you should start doing in order to decrease those numbers and start to see a change in your health. And so that's just one method that we are using to actually meet the people where they are, providing access to preventive well care.
Yeah,
I think having access to preventive health screenings is very critical, and it's important to the population while we are dealing with some of the emerging challenges. Our fight against tobacco use has been a long drawn one, and it's been challenged now with newer tobacco products, e-cigarettes, vaping, and so in lieu of that, Arkansas Department of Health last fall started the Be Well Arkansas program. The Be Well Arkansas program is a holistic approach to address tobacco cessation, high blood pressure, and diabetes, and giving a positive message about living well and being a parent, being a grandparent, and by embracing positive health behaviors like regular physical activity or making healthy choices, an easy choice when it comes to food, or staying away from tobacco use and so forth. So while we can celebrate our success in decreasing the tobacco use over the last 30-40 years, we have newer challenges we have to fight with in the form of e-cigarettes, or it could be diet drinks, which is as harmful for health as the regular drinks. Now more and more studies have shown that they cause as much as heart disease or stroke like the regular drinks. So while promoting preventive health screening, we also have to be cognizant about newer temptations or newer things coming to the to threaten the health of the state.
Decline in tobacco use was kind of offset by the rise of the drive-through fast food restaurants. Exactly. Dr. Thompson.
Well, I think we do need to celebrate some policy success and give credit to the leadership and the members of our General Assembly and on the executive team. The legislative session this year raised the purchase age for cigarettes and for tobacco products and e-cigarettes to 21. We know that nicotine is as addictive as cocaine.
Some retailers have done the same.
Some retailers had previously done that. Some have joined since. I think nationwide, if we can keep people from starting to smoke in their teenage years and becoming addicted to nicotine, that will have the single largest policy effect on the number one cause of conditions still in this state today, tobacco. I think there are other things that the General Assembly did 2 years ago. They adopted a health in all policy amendment, and so if we can extend that, and I think it is happening with county judges, with community mayors, with members on town councils, so that in every one of their decisions, when they're allowing a new suburb to be developed in a community, are they going to require sidewalks to be part of that development so that people can actually walk safely? Are we going to invest in park systems so that there's a place for folks to have physical activity? When we look at zoning issues, are we actually looking to require sources of healthy food, not just retail of any type in development efforts? These are policy angles that can be used to drive health forward.
Ms. Love, snap your fingers and you can get anything you want from the legislature and or the governor.
Wow.
What would you ask for? What would you snap for?
I would snap for, I think, plain language. I would like to see some health education materials and cultural competency materials that it's being provided to all healthcare providers, all healthcare students, and health professionals, so that when someone walks into the doctor's office, we are all talking in the same language and everyone will be able to understand it, from the 5-year-old to the 90-year-old.
Better communication.
Yes.
Dr. B?
Dr. Thompson mentioned about health in all policies. That would be a dream for the state to move forward and engage private and public entities in bringing them together, because health, everyone has a stake in health. So health and truly implementation of health in all policies would be a dream for me.
Dr. Thompson?
I would like to have the General Assembly, each and every one, recognize that this zip code risk is going to drive healthcare costs and productivity decreases in the future. That not by scapegoating an individual group or individuals, but by recognizing that where people grow up, where they live, has a long-term outcome. And through that, then, I think policies would be developed to address those disparities, and we would end up closing those gaps and moving our state in a very positive direction.
A couple of years ago, 3 or 4 years ago, in fact, I was writing a piece and I asked for some data from the University of Arkansas for Medical Sciences, and the question was, suppose a lady presents with very early breast cancer, how would it cost to effectively, aggressively treat? And I was told $10,000. If the woman presents with stage 4 late, what does it cost? $100,000. Now, not to equate human life with dollars and cents, That's some pretty profound. It's a $90,000 difference in just one case.
And with technology advancing, with the treatments becoming ever more expensive, those numbers are going to grow and the differences are going to grow, which is why the upstream investment to prevent the breast cancer if it was associated with tobacco use, or increasingly we see multiple cancers associated with obesity. So it's those upstream issues that are going to sink our boat downstream unless we really recognize the possibility of having a healthier, lower risk population.
Ms. Love, you get the last word on the program.
Oh, wow. I would just say that I think all of the agencies here are doing a great job, and I think that collaborating together regularly like we've been doing to continue to impact Arkansans in a healthy way is what we should keep working on.
Got to end it there because we're out of time. Please come back another time, everyone.
Thank you. Thank you.
Thank you for joining us, and we'll see you next time.
Support for Arkansas Week provided by the Arkansas Democrat-Gazette, the Arkansas Times, and KUAR-FM 89.